And welcome everyone to the last episode of the week in the development and analysis of human movement. This is the ankle and the foot. So we're going to give an overview of the general anatomy of the foot, talk about the normal alignment and positioning within the foot and the ankle, and also develop a fundamental knowledge of the techniques to identify these, correct positionings within the ankle and the foot. The bones. So the ankle is superiorly supported through the talocrural joint. Okay, and what happens in that is that the tibia goes down from the knee all the way down and creates this medial malleolus here, and that's the bone that you feel kind of that pronounced bump on the inside of your ankle that you feel. That's your medial malleolus. And then if you move to the other side on the lateral aspect, you'll see that there's the lateral malleolus. And that lateral malleolus is actually the distal end of the fibula. Okay, these bones, once we see the talus, as we look at that, you'll see that it'll sit right in here. Now the lateral malleolus extends further distally than the tibia, providing a little bit of extra bony support to the ankle laterally. That's why when we do roll our ankle, we typically roll it in an inversion manner or in towards the midline because we have a lateral bony support there to help us. Okay. If you notice, the tibia is larger and it's the only true weight-bearing bone within that lower leg. It's kind of a triangular shape. I apologize. It's a triangular shape. And then the fibula sits in line with the posterior border of the tibia as well. So it's a little bit further back. Okay, so if you remember from lab when we palpated, that fibula was further back than the anterior portion of that tibia. And then there's an interosseous membrane that connects the two bones, and it provides attachments for some of these muscles in there. Okay? The tarsal bones. There are 7 total tarsal bones within the foot. So, as we look at the tarsal bones, what we're looking at is right down in here. Okay? So we have the largest, which is the calcaneus, which we palpated in class. Okay? It's what the Achilles tendon goes down and inserts into, and it supports most of the weight of the body when we do the heel strike portion of our gait. Then we have the talus, which sits on top of the calcaneus. So you see it right here. It's this guy. You can see it from an overhead view here. And it sits on top of that calcaneus. And this is the bone that articulates with the medial and lateral malleolus within the talocrural joint. Then anterior to the talus and the calcaneus, on the medial portion of the foot, is the talus. Okay, it's the second largest tarsal bone. Oh, sorry. Not the talus. I'm sorry, I messed up all that. Not all. The navicular is what I meant to talk about. The navicular sits anterior to the calcaneus and the talus, and it's right here on the medial side of the foot. So right here, okay? Because this is our big toe here. And so this is our navicular, okay? The navicular tuberosity is the most prominent medial portion of the navicular, and that's where the ATF bone, our deltoid ligaments kind of connect in there. And then we have our cuboid, which is on the lateral aspect of our foot. And this is distal and inferior to the lateral aspect of the calcaneus. And then in front of those, we have the cuneiforms. And those are 3 tarsal bones that just sit anterior to the navicular and the cuboid, and they just say cuneiform 1, cuneiform 2, cuneiform 3. The first is the largest of the 3, and then we number them medial to lateral. So if we look here, you can see we have the calcaneus and the talus. Okay, this is an overhead view, of course. And then anterior to the calcaneus and the talus is the navicular. Okay, the navicular is one of the most prominent points within the arch of the foot, so it supports a lot of that weight and it can be broken easily. But it's one of the big key points when we look at arches of the feet, and if you have flat feet or not, you typically monitor this navicular and do what they call a navicular drop to kind of check that. On the lateral aspect, we have the cuboid, okay? And this is what bone a lot of the lateral ligaments attach to, is that cuboid. So when we sprain our ankle, a lot of times it's within, you'll get tender here and you'll get tender on that fibula because that's the ligaments that are stretched when it rolls in. And then here, from medial to lateral, cuneiform 1, cuneiform 2, cuneiform 3. Okay? Then we have the metatarsals, and these are numbered 1 through 5. We number them medial to lateral, so we go 1, 2, 3, 4, 5. Okay, the first is, and the fifth are the weight-bearing portions of the metatarsals. They do most of the weight-bearing in contact with the ground. And then the second through the fourth are not weight-bearing most of the time. The base of each metatarsal articulates with the cuneiforms and the cuboid, and the heads of the metatarsals are the distal portions of the metatarsals and the weight-bearing portion. So you can see just based off how these are built, right? You see that they're a little bit bigger here and here. And that's because you can see where most of that weight's coming, right? So you can see how the first metatarsal is the largest, right? So if it's the largest, it probably means it supports the most amount of weight. These little white pieces here are actually just articular cartilage within it, so it's hyaline cartilage in this picture. Then you look at the fifth and you look at the wide base here on that fifth, so you see that a lot of the weight-bearing portion happens here. So if you just look at the way the bones are, you'll know that, alright, based off what we learned earlier, Wolff's Law, bone adapts to the forces applied upon it. The larger the bone, the more force it's actually having to withstand through the life cycle of our daily activities. Okay, that's why, look how small this third one is. I'm sorry, the fourth one right here is, right? It's very thin. The third's pretty thin. The second's a little bigger, right? So it's still helping with some of that weight support, but it's not a primary weight support. But the third and fourth, very small. They do not support much weight within the average life cycle. Then as we move to the end, we have the phalanges. So you see I compressed this photo over here to make room for this big one here, but it's the same as this. Okay? So the phalanges are the same composition as in the hand, right? So it's the same end. So the big toe has only 2 phalanges, and then the rest of the hand, fingers, in this case, the rest of the toes, all have 3. Okay, they're numbered 1 through 5, medial to lateral. First phalange has a proximal and distal phalanx, but no middle. And then 2 through 5 have middle, proximal, and distal phalanxes. So, if you haven't figured it out yet, we do divide the foot, as we're talking about it, into 3 different kind of areas, right? So first we talked about the tarsal bones, right? So we talked about the talus, the calcaneus, the navicular, on the other side the cuboid, and then cuneiforms 1 through 3, right? And that's the tarsal portion of the foot. Then we have the metatarsals, right? Those are the big bones in the middle that go from the tarsal bones to the toes. And then we have the toes, which are called phalanges. Okay? So we call that actually, now that you know that, phalanges are the forefoot, okay? Along with the metatarsals, the midfoot's the navicular, cuboid, and cuneiforms. So this little section here, right? And then the hindfoot, which is just the calcaneus and the talus. Okay, hindfoot, calcaneus and talus, midfoot, navicular, and all the cuboids, the small little bones right there. And then the forefoot is the metatarsals and the phalanges. Okay? Motions. So if you look here at top left, we have dorsiflexion. So the dorsum of the foot is flexing. It's coming towards the tibia. Okay, so the top of the foot comes up. Then we have plantar flexion. And plantar flexion is when we push down. So you plant your foot, if you think of it in a sports analogy, you plant your foot, you push down into the ground. Then inversion is where you bring the big toe towards midline of the body. Okay? So that first phalanx and phalange will come in towards midline. Eversion is the big toe moves away from midline. Okay. Then we have AB and adduction, which is more of a rotation of that. It's more in the transverse plane. Okay. And we do have a supination and pronation, and that's a combination of supination is a combination of plantar flexion and inversion. Just think you're kind of rolling the midfoot towards midline and opening that palmar surface of the foot towards open. Think of it just like this: supination with your hands, right? So I'm taking the bottom of my foot and bringing it up like that as well. And then pronation would be down, so pushing it down. So if you have flat feet, you're pronating typically. And if you have high arches, you're usually supinating. Plantar flexion, the correct amount of range of motion with that is 30 to 50 degrees. And dorsiflexion, the correct amount is about 20 degrees. I'm not going to make you worry about inversion and eversion at this point in time. So then the joints, right? We have the tibiofibular joint, and that is a superior and inferior portion. So you look at the superior portion, and that's more in the knee, where the fibula and the tibia kind of attach. And we talked about that in the knee video. But now we'll look at the distal portion, which is the inferior tibiofib joint, which is this tiny articulation here. Okay. There's a syndesmosis between the two, and it kind of helps support these joints. Neither are technically part of the ankle, yet they serve as a critical function in stability and just maintaining stability within that talus and that talocrural joint. Much of the ankle strength comes from the strong union in this joint. So if these two, if you get a high ankle sprain, you typically rip the tendon that holds these two together, and now you lose that stability. And that's why it's so hard, because then when you evert and that talus hits this bone, this fibula, it's going to push it lateral, and then now it opens that joint space, making the ankle unstable, and that's why it's very hard for athletes to come back from a high ankle sprain, and it takes much longer than a typical inversion or eversion ankle sprain. So the talocrural joint is the distal tibia, talus, and the distal fibula. You've heard me talk about this a bunch already, and this is what it looks like here. Okay, so you see the articulation here between the talus and tibia. You see the articulation on the lateral portion between the talus and the fibula. Okay, if you look at this line here, you see kind of the axis of rotation, how it kind of moves. So it doesn't move at a straight up and down pattern. It moves at this kind of angular pattern right here, about a 10 degree to 12 degree angle, you would say. Okay, if we look at it in terms of the talus moving on the tibia, we see here that they're moving in the same portion, right? Because it's a convex on concave articulation, concave tibia, convex talus. So as the talus moves anterior, the toe moves down. So they're moving in the same direction, right? And then posterior, when we dorsiflex, the same. So as the talus moves backwards, the distal end moves backwards with it. Okay. We call this here a mortise joint, right? Because it's kind of like a brick fitting within a spot of other bricks. Okay. And it's a notch you cut up from a piece of wood, and that's what a mortise is. So that's why they use it. But I use a brick because some people can understand that a little bit better, because not too many people are woodworkers anymore. The tib fib create the mortise right here, and then you just slide that talus right on in. Okay, it controls most of the motion of the foot as it relates to the leg. The axis of rotation we discussed here, the lateral malleolus extends further distally, and we've talked about that and its role in stability. During plantar flexion, the ankle moves down and it adducts, so it comes in as you push your foot down. You'll see that as you push your foot down, it kind of goes in towards midline and it moves, the toes move down. And the end feels of plantar flexion and dorsiflexion are firm due to the soft tissue stretches we feel from the Achilles tendon and the anterior tibialis as well. The subtalar joint, aka the talocalcaneal joint, is the inferior talus articulating with the superior calcaneus, and it's inversion and eversion that occurs at that joint. Okay. Then we have the transverse tarsal joint, which is the mid-tarsal joint. So this is between the talus and the calcaneus with the navicular and the cuboid, and that's what's highlighted here in this yellow. Okay, very little motion occurs here, and it's very important in inversion and eversion. So if you lose this stability, you're going to lose a lot of. It's often typically related to this joint. The metatarsal phalangeal joint. So that is where the metatarsal heads articulate with the proximal phalanges. It's 5 joints. Okay, it allows for metatarsal phalangeal flexion. Right, we have 45 degrees there. Metatarsal phalangeal extension, so lifting our toes up off the ground. Flexion is curling our toes. Right, extending our toes. Right here would be 90 degrees. And then the second and fifth metatarsal phalangeal flexion is 40 degrees, right? And then the second to fifth metatarsal phalangeal extension is 45 degrees. Okay. The second toe is a reference for AB and adduction. So you see here. Okay. Abduction, reference because it's moved away. Adduction because it's close off that second toe. Ligaments. The ankle joint is a synovial joint, and it's mostly held together by the deltoid ligaments on the medial aspect of the ankle. Okay, so we have medial triangular ligaments, and those are the tibio-navic, tibio-calcaneal, and the tib-talar. Okay, so the tibio-navicular attaches what? The tibio, so the tibia, and the navicular, and the so the navicular. So tibio-navicular, right here. See it? Then we have the tibio-calcaneal. So what would that support? Tibio, tibia, calcaneal, calcaneus. Okay, so that's there. We have the tibio-talar, which is in the back, so the tibia and the talus, and that supports, you know, anterior and posterior motions of that talus for us. So collectively, we typically just call that the deltoid ligaments. And that's what I want you to understand. But know that it's a tib-navic, tib-calcaneal, and tib-talar joint ligaments that actually attach that. You also have this little guy here. That's the spring ligament that can often be torn as well. And that's between the navicular and the calcaneus, and it kind of provides some lateral rotational stability of this calcaneus as it inverts and everts. We also have lateral ankle ligaments. These are the most common injury because, as we said before, these guys are going to get more of a compression injury, right? Because they're on the medial aspect of the ankle. So as that ankle rolls in, you roll your ankle and it rolls in, these guys are going to be compressed. So almost like a bruise, like if you got hit with a baseball in your quad. That's kind of how this will react. These, on the other hand, undergo a tension aspect, and they get a tension type of injury. The lateral ankle ligaments, sorry, I saw an email pop up. The lateral ankle ligaments connects the lateral malleolus to the talus and the calcaneus. And we have the ATF ligament, the anterior talofibular ligament. This connects the talus and the fibula. It is a weak ligament, and that is why this is the #1 ligament and #1 area that you have pain in when you sprain your ankle. Okay, it is right here, the anterior talofibular. Okay, ATF. Okay, then we have the posterior talofibular ligament. So if you notice, talus, fibular, fibula. Then we have the posterior talofib, once again, talus and fib, right here. And this guy doesn't get injured too much, but he does very rarely get injured. You'd have to almost land in a maximum dorsiflexion and invert that ankle or twist that ankle somehow to actually injure that guy. It's a fairly strong ligament as well. And then calcaneal fibular, this guy sometimes gets caught as well because you go probably about 40% of, or about neutral, foot neutral, when you would actually roll this ankle. So it would be flat on the ground and you just roll over it, versus the anterior talofibular, you're typically in terminal plantar flexion and you invert that ankle, and that's when that gets hurt. This is terminal dorsiflexion when you get hurt with this one, and this one's more in neutral position, and that's the calcaneus to the fibula. and it's vertical and long, and you see that here. Then as we stand, we have arches. So everyone's heard about, I have poor arches. My arches hurt in their feet, right? But what arch are we talking about? So we stand on a triangle of distribution between the weight and on our feet. Okay, it's typically 3 points: calcaneus, the first metatarsal, and then the fifth metatarsal. So if you actually look at your shoe, you'll probably see that these points on your shoe are pretty worn out. And if not, you have an altered gait pattern, and then we'd want to probably check out your arches. Okay, so the most common arch is the medial arch. Okay, this is the arch we look at when we are typically getting evaluated for I have poor arches. It makes up the medial border of our foot. So you see it here, calcaneus to first metatarsal. Okay, the talus is at the top of this arch, and the talus receives the weight of the body through the tibia and the fibula, and it distributes it through the arch. The arch depresses, goes down like a spring, and recoils when it's unloaded. Normally, it never flattens or touches the ground. If it does, we have a problem. And that's where you look at that navicular. You watch this navicular, you step on it, you watch it go down, and then it should rebound as you lift the weight off. And that's why they see how much. If you have a heavy navicular drop where this goes way down, then we know we have some type of instability in here that's causing that foot to depress. A lateral longitudinal arch, the calcaneus to the cuboid, so that's from the fourth to the fifth metatarsal. Okay, so that's on the outside here. You see calcaneus to the fifth metatarsal, sorry, and this rests on the ground during weight bearing. It's a pretty shallow arch. While this arch looks long or looks very steep, it's really not. It's typically pretty flat. Most people don't have too much issue with that. This transverse arch, on the other hand, this runs from side to side through the 3 cuneiforms to the cuboid, and it's the second cuneiform that bears most of the weight of the arch. So you see here, right? So this is right in front of it a little bit, some more right here, right? So we're looking at this arch. And if you look, that can get kind of compressed. This cuboid can move out, it's touching the ground, and then the weight, as it goes up to this peak brick here, this is where most of that weight's going to compress right in there. Ligaments and fascia support these arches. The spring ligament we mentioned earlier really helps support that medial longitudinal arch, right? So sometimes that could be torn, and we kind of figure out why that is, or it's stretched, right? We need to shorten it, make it tighter to help support that medial arch if we have a navicular drop, and we need to figure that out. The long plantar ligament, okay, it's right here. You see that here? From our first cuneiform to the calcaneus. So you can see how that's going to help support this arch as well, right? And if you remember our box man, I said triangles are strong, right? So we have a triangle between the first cuneiform, the calcaneus, and then the top of this arch. You see that right where the talus hits is actually a little triangle, right? Just like the spring ligament's a little bit of a triangle as well, it's just very short, okay? And then we have our short plantar ligament, which goes from the calcaneus to the cuboid, and it lies deep in the long plantar ligament, or deep to the long plantar ligament, so it's a little bit further in. You can't really feel these too much, okay? But you can feel that plantar fascia, and that's the calcaneus to the proximal phalanges, okay? And so what we have there is it keeps the calcaneus and talus from separating from the tarsals and the metatarsal heads as we put weight on it. So you can see it right here, that plantar fascia. Okay, and that typically gets tight on some people. And if it is, then you need to figure out why more of that happens. Okay, the extrinsic muscles of the foot. Let's get into those. So these muscles originate on the leg and they move into the foot. There's a vertical line of pull with these, and the foot acts as a pulley. So in anterior dorsiflexion, the foot anterior dorsiflexes the foot and extends the toes on these extrinsic muscles. Posteriorly, the plantar flexes the foot and it flexes the toes. Medially, so like these are all the locations of where these muscles are. So if you look at the anterior of the foot, posterior of the foot, medial aspect of the foot, these muscles invert the foot. The lateral muscles on the leg, they evert the foot. And then there's groups of 3 in 4 compartments. Okay, so the anterior, posterior, superficial, posterior, and the deep posterior. All of these originate on the femur, tibia, or the fibula. If this is confusing, don't worry, we're going to clear it up. So the posterior compartment. So the posterior compartment is the gastrocnemius, the plantaris, and the soleus muscle. Now in lab we palpated the gastroc and the soleus, right? So the gastroc, as we identified in class, it originates on the medial and lateral femoral condyles, and it inserts on the posterior calcaneus down here. It's responsible for knee flexion and ankle plantar flexion. Okay. The soleus originates at the posterior tibia and the fibula back here, and it inserts on the posterior calcaneus, and it does ankle plantar flexion. Then this little guy here, your plantaris, right? That guy does posterior lateral, it originates at the posterior lateral condyle of our femur, and it inserts on the posterior calcaneus, so once again into that Achilles tendon, and it's weak in assisting with knee flexion and ankle plantar flexion, right? So it just does a little bit. Look, it's a tiny little muscle belly. It doesn't do much. It's just enough to give it a little extra oomph, and it helps with that knee flexion because it does cross the knee joint, and it assists with that ankle plantar flexion because of this long tendon putting the force into that Achilles tendon. So then we have the deep posterior. So we're going by compartments, as you remember from here, right? I said the groups of 3 and 4 compartments: anterior, posterior, superficial, posterior, and the deep posterior. So now we're on the deep posterior. And if you want to remember this, remember it as the 3 amigos: Tom, Dick, and Harry. Okay? Tom is the tibialis posterior. Okay? That originates at the interosseous membrane. So if you remember that interosseous membrane, I said that happens between the tibia and the fibula. Okay, so this originates there, and it inserts on the navicular and most of the tarsals and metatarsals. So it kind of goes underneath. Okay, so you see it here. And you see it does ankle inversion and assists with plantar flexion. It's the deepest of all those deep posterior. So you see it here, starting here. The 2 heads, kind of, not 2 heads, it's 1 head, but it's that bipennate type muscle. And you see that each side of that pennate has kind of its own little origin here. And then it comes down, and you see navicular on the medial aspect of the foot, and then it kind of touches all these heads of these metatarsals right here. Okay? And then we have the flexor digitorum. So if we're just looking at it from here, it's like, what do these do? This is the digitorum, so the digits, and it flexes them. Okay? So it's the posterior tibia and distal phalanx, so the 2nd through the 5th phalanges, 2 through 5. Okay? And it flexes the 2nd through the 5th toes, and it assists with inversion and plantar flexion. And then I'm going to jump and just do the flexor hallucis as well, since we're here. And the flexor hallucis, so what does that do? It flexes the hallucis bone, so the big toe, and it originates at the posterior fibula, and it inserts on the distal phalanx of the great toe, and that flexes the great toe and assists with inversion and plantar flexion. So let's jump back here. So how do these assist with that, right? Look at these lines of pull. So of course, though, if this tightens up, it's going to pull this muscle this way, right? Because it's going to shorten, and then if you think, pulls it there, right? Because it's on the inside, that medial aspect. So it's going to help with some of that inversion there. And it's also going to help with a little bit of plantar flexion because it's on the bottom of the foot, right? Because it's a flexor, so it's going to actually run underneath these bones, right? And then the flexor digitorum longus runs underneath, right? And it helps with inversion and plantar flexion. So once again, underneath helps pull it down. And if it tightens, it's going to pull it in, right? Inversion. So if we look at the anterior compartment, we have the tibialis anterior. Oh, I'm sorry, I didn't go over that. So Tom, Dick, and Harry. So tibialis posterior is Tom. Dick is the digitorum. And then Harry is the hallucis. So tib posterior, flexor digitorum, flexor hallucis. Tom, Dick is the digitorum, and hallucis is Harry. Okay? So anterior compartment, tibialis anterior. It's the lateral tibia it starts at, and it inserts on the first uniform and the first metatarsal. So if it inserts there, what's it probably going to do? It's probably going to help with some inversion, and it's also going to dorsiflex because it's on the anterior, the front of the foot. So if it shortens on the front of the foot, it's going to pull it up, right? Thus creating some dorsiflexion. We also have extensor hallucis longus. So if you think of flexor hallucis, right, what did that do? Flex the hallucis. This is going to extend the hallucis. So this is going to extend the big toe. It originates on the fibula and the interosseous membrane, and it goes down and inserts on the distal phalanx of the great toe. So as I said, it extends the great toe. And then we have extensor digitorum longus. What does that do? Extends the digits. So it also sits on the anterior portion of the leg here, on the fibula, the interosseous membrane is where it originates. And it goes down and it inserts on the distal phalanx of the toes 2 through 5. You see it here. And it extends these toes and assists with dorsiflexion. So we can look at it a little closer. Here you go. Okay. Extensor digitorum. Right? It sits right over the top. So when you lift your toes up with your socks off and you see those little lines, that's what you are looking at right there. Flexor or extensor hallucis extends that great toe. And tib anterior. This is the big meaty part that you can feel right on the lateral aspect of that tibia. So if you feel your tibia, that ridge, and move laterally, that big meaty piece right there, when you lift your ankle off the ground, that is your anterior tibialis. Then we have the lateral group. So these are what we just kind of call our perineal muscles, but now they call them your fibularis muscles. Okay, so your perineals or your fibularis, I'm fine with either of them. I still call them my perineals because I learned them as perineals. But if you want to call them your fibularis muscles, I'm completely fine with that as well. Okay, you have fibularis longus, fibularis brevis, and fibularis tertius. If you go by perineal, perineal longus, perineal brevis, perineal tertius. Okay? They originate on the lateral proximal fibula and the interosseous membrane. They insert on the plantar surface of the first cuneiform in the metatarsal. Okay? And then it does ankle eversion and assists with plantar flexion. And then longus or brevis and tertius here, these little guys originate at the lateral distal fibula, and then respectively for the tertius, they originate at the medial fibula, so distal, medial, and they insert on the tuberosity of the base of the fifth metatarsal, both of them, and then they do eversion and plantar flexion, and then tertius does eversion and dorsiflexion. Why? So you see brevis underneath, that'll do plantar flexion, right? But you see fibularis tertius over the anterior portion, right? So that guy, what he's going to do is he's going to do a little bit of dorsiflexion because it's on the anterior portion, right? That muscle belly crosses to the anterior and lifts that up. But they both do eversion and help pull these up. That's why you'll get some of this pain. If you didn't break your ankle, you'll get pain up in here sometimes because these muscles strain, and they're not very big as you can see. They strain to pull that ankle back when you start rolling it in inversion, so you get a strain injury on those lateral muscles there. And then we have these intrinsic muscles. I want you to know every single one of them. I'm just kidding. I don't want you to know any of them, honestly. Just know that they're there, okay? So you have these adductor muscles on the meat of your foot underneath here. You have your flexor hallucis brevis, flexor digiti minimi here, your plantar ligaments here. And you see that how just there's so many little tiny little muscles within that. Just like in our hands when we have our lumbricals between each hand, each metacarpal up here, you have the same in your foot between each metatarsal down there. They have both attachments are in the distal ankle joint. They're all small and they all are located on the plantar surface except the extensor digitorum brevis and extensor hallucis brevis and dorsal interossei. Okay, some common pathologies. Shin splints. It's a general term for pain along the medial tibia. It's commonly an inflammation of the periosteum, which is a film that wraps around the bone to help kind of keep that healthy. We learned about that when we went over bone properties. And it's typically an overuse injury. Also wrapped in with that is what they call MTSS, medial tibial stress syndrome. This is anterior leg pain not associated with a stress fracture. Pes cavus is an abnormally high medial arch. Pes plantis is a loss of that medial longitudinal arch. Hallux valgus, okay, this is what we call bunions, right? How it's caused by the great toe development and what causes valgus deformity. So it's moving in, so you get your toe goes out and in like that. It's what we call bunions. Hallux rigidus is pain and diminished range of motion in that first metatarsal phalangeal joint. Okay, rigid hallux. So the big toe is rigid. Metatarsalgia. This is pain around the metatarsal heads. This happens because a lot of times there's nerves around that metatarsal head, and that kind of causes some irritation within there. Linked to that is Morton's neuroma, where there's abnormal pressure on the plantar digital nerves, commonly between the third and fourth metatarsals. Typically, that big toe, a way of kind of knowing that you could have this, is that second toe is actually longer than the first toe. Then we have turf toe, which is a hyperextension injury of the first metatarsal phalangeal joint. So the great toe bends too far back, okay, higher than that 40-45 degrees. That ankle sprain, right? It's most common and often due to a stretch injury of the lateral medial ligaments. We've talked about that. We've talked about an ankle fracture of that lateral malleolus on that fibula, because that's such a bony, hard, rigid support that could happen there. And then plantar fasciitis, which is often a pain in the medial or in the heel from an overuse of the muscles that support the medial longitudinal arch. More of a fatigue injury than anything else most often. That is all we have today. So I hope you enjoyed this recording, and watch out for the tests. Take care. Have a great weekend. Booyah.